I'm Dr. Seethala. I'm one of the cardiologists, heart failure cardiologist at Boise, and our clinic treats heart failure and pulmonary hypertension. That's what we do. And with regards to uh, my clinic here, like everyone think about being a physician is a great thing, but I will proudly tell it's my team that makes me good here. Not about me, it's about my team that makes me really good, like more than anything else. And I just need to be honest about that. And can we go to the next slide? So, disclosures, I'm on speaker bureau for Bristol Myers Squibb. I speak on the behalf of a drug called mavacamten, which is a specific drug for hypertrophic cardiomyopathy. I'm not talking about the drug during this discussion at all. We are not going to even touch about hypertrophic cardiomyopathy. That's my son when he is 1 year old or 1.5 year old, and he wants to read about clinical guide to heart transplantation at that age. And he makes my life. Okay. Learning objectives, we will try to learn about heart failure definition, epidemiology, heart failure physical exam finding, ischemic cardiomyopathy and its percentage in heart failure, guideline directed heart failure management, acute ischemic cardiomyopathy and wearable cardioverter and defibrillator, implantable cardioverter and defibrillator indications. Next slide, please. So, what is heart failure? Like, is it a low EF that makes the heart failure, or is it a patient having the symptoms? It's not a single pathological diagnosis. It is a clinical syndrome consists of signs and symptoms of heart failure. What are the symptoms? Shortness of breath, ankle swelling, and fatigue are the classic symptoms. And signs are elevated JVP, pulmonary crackles, and peripheral edema. Heart failure is a complex clinical syndrome with symptoms and signs of heart failure that results from structural and functional impairment of ventricular filling or ejection of the blood. The difference between the first and second definition, one is by ESC, another one by Heart Failure Society. The second definition includes more about HFpEF2 and more than just having a low EF. Next one. So epidemiology, like why do we need to care about heart failure? And truly, we have roughly 425,000 deaths, accounting for 45% of cardiovascular deaths in United States in 2022 are from heart failure. Lifetime risk for heart failure has increased to 24%, and approximately 1 in 4 individuals will develop heart failure in their lifetime. 5 to 7% of the patient have a symptomatic heart failure, have an advanced heart failure. What it means is they need a mechanical heart or transplant. And heart failure accounts for $32 billion as a direct medical cost to our healthcare system, $14 billion as an indirect cost in 2020. With the projections, it is going to go up to $142 billion by 2050. And other analysis suggests that cost of heart failure may be as high as 227,000 in 2020, and with the projections up to $858 billion. That's pretty much a significant amount of our healthcare costs going into heart failure. Next slide. So then, what are the main causes of heart failure? And the common causes of heart failure are ischemic cardiomyopathy is the number one, and the next in highest in the ranking is hypertensive cardiomyopathy, and the next one is valvular cardiomyopathy. True non-ischemic cardiomyopathy is only 10%. That does not include either any genetic cardiomyopathy we are talking about. And truly, ischemic cardiomyopathy takes major chunk of your heart failure patients. Next slide. So, how do we classify heart failure? That's a bigger question that comes. Number one, is it by ejection fraction? If you have an ejection fraction less than 40%, everyone agree that it's a heart failure with reduced ejection fraction. And if it is greater than 50%, we will call that as a heart failure with preserved ejection fraction. And between 40 to 50, we will call as a heart failure with mid-range ejection fraction. And LVEF is a component, but all of them has to have signs and symptoms of heart failure in order to call them that they have a heart failure. Otherwise, we should call them as a cardiomyopathy. In order to solve this problem, ACC came up with a staging of a cardiomyopathy. Next slide. So they staged the heart failure into stage A, B, C, and D. What A means is truly at high risk, like people who have a diabetes, obesity, cardiovascular disease, or are getting exposed to chemotherapy and genetic variant of cardiomyopathy. They do not have either low EF, but they are at a higher risk, nothing else, nothing more. Stage B is the people who have a structural problem. What it means is if they have an LVEF less than 35% or so, we call them as a stage B cardiomyopathy. And stage C cardiomyopathy means they have either low EF plus and symptoms. Most importantly, symptoms makes stage C cardiomyopathy. Stage D cardiomyopathy means like they have heart failure, they are refractory heart failure, they needed to have an escalation of heart failure therapies, and they need to have a mechanical hearts or transplants or palliative inotrope. They call as a stage D cardiomyopathy. Next slide. So symptoms classification, NYHA class 1 to 4 are the classic classification. Why it is important? Because if we are going to classify appropriately, everyone will be on the same board when we are talking about NYHA class 1. Class 1 means no physical limitation with an ordinary activity. More than usual activity can cause fatigue. Stage 2 means like, they have slight limitation of physical activity. Stage 3 means marked limitation of physical activity. And stage 4, symptoms of heart failure at rest. Any physical activity causes discomfort. Next slide, please. And then we have new onset of heart failure, then resolution of symptoms but still have a heart failure, and persistent heart failure, worsening of heart failure. We can classify that too. And other than new onset of heart failure, rest of them are you can include into worsening of heart failure will go into stage D cardiomyopathy, and resolution they can move from stage C to B and B to C, and they can jump from B to D too. Next slide, please. What is the role of ejection fraction? Everyone likes echocardiogram, that includes myself. And how do we define heart failure? Does ejection fraction determines heart failure? Answer is no. You can have heart failure with preserved ejection fraction. So it is important in classification of heart failure. Is it a HFrEF or HFpEF? And next important role it has is to define prognostication. And then we have another common problem I face in my clinic all the time is they say, oh, my LVEF is improving. Like, I used to have an LVEF of 27%, now I have 30%, and my LVEF has improved. Does it truly 27 to 30% means really improved LVEF? Answer is LVEF determined by lots of other factors. That is preload, how much volume they have, how much blood pressure they have, and what are the circumstances they are in when we are doing echocardiogram. Then other question comes is how often do we need to do echocardiogram? Anytime when we have a change in the clinical status, we should do echocardiogram, and otherwise we don't need to do an echocardiogram on a regular basis unless we have some other good clinical reason to do it. Next slide, please. So then next question comes is like physical exam and biomarkers. What is the best physical exam to tell whether the patient is in heart failure or not? They did a study on this to see which physical exam finding is more sensitive and specific. This is like positive predictive value of JVP is around 75%, and hepatomegaly is 78%. But if you look at the negative predictive value is only around 39%, and hepatojugular reflux is 65 and 49%. So truly, JVP is one of your best marker for sensitivity of heart failure. Next slide. And then we have a 2x2 classification. Why this is important? Because it was done long back, and it gives us what is the patient doing and how the heart is responding to the low ejection fraction. Hot and dry means they have a normal wedge and normal cardiac index, though they will have a normal mortality rate. And hot and wet, what it means is their extremities are warm to touch, but they have lots of fluid. We can diurese them. And then we have a cold and dry. What it means is they have uh, cold extremities, and dry means they don't have any high intravascular volume. So they have a wedge pressure is low and cardiac index is low. And then we have a finally cold and wet. This cold and wet has a highest mortality of all the 2 by 2 classification. Next slide. And how do we examine the JVP exam? We need to do at a 45 degree angle, and we need to measure from manubrium sterni to the top part of your JVP. And it has a sensitivity of 65% and a specificity of 64%. Next slide. And then we have another recently added physical exam finding that is called proportional pulse pressure. It is the difference between your systolic and diastolic pressure. If you have a higher diastolic pressure and a lower systolic pressure, your heart is not pumping enough. That's what this proportional pulse pressure means. If you have around 25%, you have a curvilinear, and if you have a proportional pulse pressure higher than 25%, you are more likely to have an advanced heart failure. Next slide, please. And this is a classic slide from maybe we forgot all of this old slide, and Valsalva maneuver and heart failure. How does it do that? And when we have a Valsalva maneuver, the classic response is overshoot at the end of your Valsalva maneuver. And if we have not seen that overshoot at the end of the maneuver, then that is a classic sign for a low EF. And square root pattern is also pretty bad prognostic marker. And particularly if you have any patient in your ICU with an arterial line, this is easy to do. And all you ask them is, can you bear down for me? And you will see it in the arterial line about this. And specificity is almost 91% for a bad heart failure. And sensitivity is around 69%. And next slide, please. And then we all want to know about brain natriuretic peptide and the N-terminal pro-BNP. It is important to check it to diagnose or exclude heart failure. And if the patient is getting admitted to the hospital for a heart failure, it can help us to establish the prognosis. And also, it also helps us to have a risk stratification. And in patients who are hospitalized for a heart failure, a pre-discharge BNP can be useful to inform the trajectory of the patient and establish a post-discharge prognosis. So these are right from the guidelines that we took the slide from. It is up to class 2A recommendations. And then we can go to the next slide about ischemic cardiomyopathy. That has to be our, the title of the topic is ischemic cardiomyopathy. And as we mentioned, it is 33% of the people have an ischemic cardiomyopathy as a etiology for low EF. And when do we do ischemic evaluation? And what kind of ischemic evaluation we need to do? Is it a coronary angiogram, or is it like coronary CT scan, or stress MRI, or nuclear stress test, stress echocardiogram? We have so much. And everything has to go back to one basic premise. What are the risk factors for coronary artery disease? And what do we think about this patient's medical compliance? What is the age of the patient is? What is the history of drug use and alcoholic usage? If the patient is coming to the hospital with a low EF and my drug screen is positive for meth, I don't recommend to do any ischemia evaluation, because once we do an ischemia evaluation, if they open a stent and we are not 100% sure whether they will take the medication or not, truly, stents never showed any mortality benefit other than in the setting of stemming. It's the medical management that shows the mortality benefit. All the stents do is to decrease the chest pain episodes. That's pretty much it, other than the setting of a STEMI. Why I mentioned about the age. Recently, we published two articles. One is called Revived BISIS 2 trial. Another one is Ischemia trial. In those two trials, people who are above the age of 70 and randomized into PCI versus medical management. Medical management won, not the PCI. And why medical compliance is important? Because these people need to take a dual antiplatelet therapy. If they are not going to take it, we might be doing more harm by doing PCI than helpful for them. That's the place where the risk factors for coronary artery disease comes handy. Next slide, please. Then methods of ischemia evaluation. If you have a very high risk patient to have a coronary artery disease, we should do a left heart cath. Everything goes back to one thing called Bayes theorem. And if you have a high pretest probability, and if your intermediary test is negative, that's false negative. And if you have a low pretest probability, and if you do a test that is positive, that is false positive. That's what the Bayes theorem tells. If you have a high risk patient, like for example, if a patient has a coronary artery disease and bypass surgery, if he's coming into the hospital for chest pain, no point of doing a stress test. Directly take them to the cath lab, because even if stress test is negative, it's most likely it's a false negative. And then we can do a coronary CT with FFPAR, and that also gives a very good ischemia evaluation. But the downside of it is if it is positive, you need to take them back to the cath lab. And low to intermediate risk people, cardiac stress MRI and nuclear stress test and a PET stress test are the important way of doing ischemia evaluation. One other place where the nuclear stress test has important role is to determine how much myocardium is involving in having issues with coronary artery disease, like percent of myocardium involved, and that helps us. And we will switch to medical management now, how to do the ischemia medical management for ischemic cardiomyopathy. Next slide. So there are lots of clinical trials that determined what we are doing in heart failure management. First drugs that came into the market showed a clean-cut mortality benefit is RAS system controller like AC inhibitors. The first trial is in consensus trial in 1987, and before that there is a captopril trial that was done, showed clearly mortality benefit. Initially, all the clinical trials for all-cause mortality rate and relative risk reduction of enalapril versus placebo is 0.6, and enalapril versus placebo in SOLVE trial is around 0.7 for all-cause mortality and heart failure hospitalization, and all-cause mortality is around 0.84. It's plus or minus same for all AC inhibitors and ARBs. And then we came up with the paradigm HF trial for sacubitril valsartan, which is most other people know as an Entresto, and they compared against enalapril. Like we have a cardiovascular mortality rate benefit by 0.8, and that's very significant. And Pioneer HF trial, ratio of change in the internal proBNP is by 0.71. So these are all important. So if patient has a significant room for the blood pressure, ARNI is recommended as a class 1 recommendation more than your AC inhibitor slash ARBs. If you have a very low blood pressure, AC inhibitors and ARBs are good alternatives for ARNI. Next slide. And then we have an MRA trials. That is, these MRA trials were done on beta blockers and also on AC inhibitors and ARBs. Spironolactone versus placebo, all-cause mortality is around 0.7, and eprenone versus placebo for cardiovascular mortality and heart failure hospitalization is around 0.63. All-cause mortality is around 0.67. And FSS trial, post-MI patients with LVEF less than 40%, all-cause mortality is around 0.92, and cardiovascular mortality is around 0.79. So truly it decreases all-cause mortality. And next slide, please. Beta blockers. These are one of the great drugs that came into the market. And first trial is Merit HF trial, low LVEF, LVEF less than 40%, and NYCHEC class 2 to 4 symptoms. And Copernicus trial, carvedilol is class 3 to 4, and Sibistral class 3 to 4. These are very sick people. And they tried these drugs and they found all-cause mortality around 0.73 and 0.19 is the relative risk reduction for all-cause mortality for metoprolol succinate. And not all beta blockers are same. I cannot say the same thing about all ACE inhibitors and ARBs have. It's a class effect. It's not a drug effect. For beta blockers, we cannot say that. There are only guideline approved medications are metoprolol succinate, carvedilol, and bisoprolol. This is because of these trials. Rest of the beta blockers did not show mortality benefit, particularly when they compared carvedilol against metoprolol tartrate. Metoprolol tartrate did not decrease the mortality. That's the reason when people are having low EF, we recommend to use metoprolol succinate, carvedilol, or bisoprolol. Next slide, please. And oh, I missed one slide with I think SGLT2 inhibitors. Forgot to add that slide maybe. And SGLT2 inhibitors is the next drug that came into the market. They have, most importantly, they decreased the heart failure hospitalization more than cardiovascular mortality, but it is a class 1 recommendation to use SGLT2 inhibitors for heart failure with low EF and also with the heart failure with preserved ejection fraction. And then the most important topic is diuretics. When the patient is hypervolemic, what dose of diuretics we want to use inside the hospital? Does all the diuretics like a Bumex, torsemide, and furosemide are same? And when do we use sequential blockade? All the sequential blockades are same is the most important question that comes into the clinical practice. Number one is the dose trial that determines what dose of diuretics that we need to use inside the hospital. 1.5 to 2.5 the time of the oral dose that the patient is taking, we should use it in the hospital if as per the dose trial. And drip versus intermittent boluses. With regards to drip, you may be able to achieve the diuresis more quickly, but you are taking a higher risk for slightly higher creatinine. And transform trial try to compare between torsemide versus the furosemide. They did not find any major difference. But all of us in our clinical practices see like, oh, torsemide works better than Lasix, but clinical practice. But in reality, trial did not show any major difference. And sequential blockade with the thiazide diuretics is the chlorotic trial that they did. And it did decrease the length of the stay by 0.25 days or something like that, but it came at a cost of higher electrolyte imbalances. And then carbonic anhydrase inhibitors, ADVAR trial, it is slightly more positive trial when compared to the thiazide diuretic trial. And it also showed like patient symptoms got better quickly. And then we have a vasopressin antagonist like tolvaptan, conivaptan. And tolvaptan is a V2 receptor antagonist, and conivaptan is V1A and V2 receptor antagonist. Everest, Eclipse, and Avanti trial, they did make the people urinate a lot, particularly if they are having hyponatremia, but did not change mortality benefit that much. And sequential blockade is by adding like different parts of the loop of Henle we can block. Most importantly, avoid NSAIDs. That's the most important part. And diuretic resistance is not uncommon. We need to keep an eye on the diuretic resistance too. And if you have a diuretic resistance, sometimes changing from torsemide to Bumex, Bumex to furosemide, they might help you. And we might need to add sequential blockade too. Next slide. And other evidence-based therapies for ischemic cardiomyopathy that are available. All these drugs were done, and particularly hydralazine and isosorbide dinitrate combination is particularly in African American patients. It is strongly recommended. It is mortality benefit, but they need to be on max doses of GDMT medications first. And then we have an ivabradine. It's based on a SHIFT trial. If they are on max tolerated doses of beta blockers, and if the patient is still having a heart rate greater than 70, we should try ivabradine. And virosiguat came into the market like in a Victoria trial, and it also like dilates the blood vessels in the pulmonary vasculature, and it also helps to decrease the heart failure hospitalization, not the mortality, but bidal combination decreases the mortality. Ivabradine decreases the heart failure hospitalization. Next slide, please. And this is a slide that give us like roughly about what we need to do, what doses of ARNI we need to start on. This is directly from the guidelines, and we like it's strongly recommended to use ARNI if patient can afford for it, and if patient can tolerate for it. If not, then AC inhibitors and ARBs are alternatives. And MRA is a great drugs of choice for triple therapy, and SGLT2 inhibitors makes it as a quadruple therapy. And we need to be careful with SGLT2 inhibitors to have a GFR, particularly with the dapagliflozin and a sotagliflozin, GFR greater than 25. Next slide. Contraindications: what are the medications that we should not do? Flecainide, propafenone, and particularly dronabinol. And dofetilide, we use it for rhythm control in heart failure, and amiodarone is safe to use in heart failure. Particularly, we need to be careful with the other side effects from it, because arrhythmia is quite common. AFib is really common in heart failure. Next slide, please. And wearable cardioverter and defibrillators. So it's Vestral, no arrhythmic mortality difference, overall mortality benefit. It's a class 2B recommendation, and it also was mentioned as it may be reasonable to consider using wearable cardioverter and defibrillator, that is your Vest, in newly diagnosed cardiomyopathy. Next slide. And primary prophylaxis ICD, the dynamite and cabbage patch trials defined like 40 days and 3 months after that. If we do the defibrillator before 40 days of acute MI or a cabbage, then we increase the mortality based on those trials. That's the reason this 45 days and 90 days waiting period came in. Next slide. And when to consider advanced heart failure therapies. Number one, when the patient is requiring IV inotropes, or patient is having significant symptoms that they cannot walk to bathroom without having trouble breathing, or resting shortness of breath, or when we are having worsening of renal function like creatinine greater than 1.8, and LVEF is coming below 20%, and patient is requiring more and more shock therapies and recurrent heart failure hospitalizations, and we need to go up on the doses of diuretics. And if the patient's blood pressure is dropping down, and we need to come down on all the GDMT because of the low blood pressure, means that their heart is failing more and more. So we might need to think about mechanical LVADs or heart transplants on those guys, or some patients palliative inotropes. Next slide, please. And how the disease progression, this is my last slide. And people will stable, something goes down and they will decline, and something happens, they will decline again. They never go back to previous level. Symptoms progress very quickly, and the time duration between these episodes will come shorter and shorter. And we need to find a sweet spot of that transition to the advanced heart failure therapies when they are still doing good, but their functional capacity is quite limited. Next slide. And key points: quadruple therapy is important. Quick up titration, strong HF trial, and titrate HF trial are the two trials that showed us that we can up titrate the GDMT quickly and aggressively, but with a caveat that you need to have a big team. It's not like I'm going to go just because I want to go. We need to go with a good roadmap, and your team has to contact the patient, and the patient knows when to call, when not to call you. And when there is nothing called when not to call you, anything you have a doubt, call us, kind of an attitude. We need to be available for them 24/7. And consider heart failure colleague consultation if we are having any doubt. We Heart failure docs are there for you guys at any moment in time. Next slide, please. And thank you. That's my email ID. That's my phone number. At any time, if you guys need anything, just give us a call. And I provided a couple of more slides at the end of the presentation about all the that's the reference. And can we go next to? So these are all the heart failure trials that determined why I do what I do. Nothing else, nothing more.
Well, thank you very much. That was an excellent overview and really helpful to have some just a little bit of repetition of things we've heard before, which is always good to make sure that we're focusing on GDMT and the evidence-based therapies for heart failure. I'd like to maybe just take 5 minutes. I'm hearing an echo. Are you hearing? Yeah. Okay, that's better. So we'll take 5 minutes just to discuss one key issue, which is revascularization. This always comes up, and obviously primary care docs are not making a decision themselves about whether or not someone should get a stent or a bypass surgery. But they're going to have to deal with the patient when they come back, and they may uh, you know wonder why does this patient who has coronary artery disease, why are they not getting bypass surgery? So I want to address this by with a case example. Okay, let's say we have someone with heart failure and reduced ejection fraction, EF of 30%, and their angiogram shows 80% mid LAD lesion, maybe a 70% RCA lesion, and a chronically occluded circumflex artery. So, what would you do with that patient, and why, and what are the factors that go into that decision?
So when we are looking at the ischemia evaluation, that's a very broad thing. So for example, if the patient has an LVEF of 20%, I will give you a different example before I go for your example. 20% distal RCA lesion. That 20% LVEF cannot be explainable by distal RCA. Like roughly 60% of your heart myocardium will be supplied by LAD. And so LAD is a crucial coronary artery. And mortality benefit in cabbage is through the Lima to LAD. It's not the SVG graft. Lima to LAD is the one that provides the mortality benefit. Any patient who have a diabetes, left anterior descending artery, has to be considered for bypass, even if it is a syntax score is less. Then if you are going to talk to interventional cardiologists, then they will talk about a syntax score, hey, it's a small juicy lesion, I can quickly stent it, less mortality. And yes, there is a less mortality in the beginning if you are doing PCI. But if the patient survived for greater than 10 years, the mortality of Lima to LAD is significantly lower, particularly revascularization procedures, like how many times they need to have a repeat cath, how many times they get admitted to the NSTEMIs to the hospital, will be significantly lower in cabbage people when compared to the PCI. So then we have another major argument comes about hybrid trial. As mortality benefit is purely from a Lima to LAD, just like doing Lima to LAD by Da Vinci technique. There are some programs that does the Da Vinci technique. If you have a multivessel coronary artery disease, I just do Lima to LAD by Da Vinci machine, and then go on and PCI to the RC and LCX. Can we do it? Answer is sure, we could do it, and some programs showed some great success with that too. Mostly it is determined by whether you have a left main or LAD that is get involved. So if the patient has a very distal LAD lesion, and maybe it supplies only the small amount of apical myocardium, opening a chest for a bypass for maybe less than 10% of an myocardium, and that won't explain that. And if patient has an LVEF of around 15-20%, and if you have a distal LAD lesion, that won't explain that. And those are all comes into the role.
Yeah, so there clearly are many, many factors. And
Many.
so I guess maybe the take home message that it's complicated and that cardiologists disagree. And I think that is the big take home message is that you will, if you ask 10 cardiologists, they will have a lot of different opinions. So for our primary care docs on this call, I think it's just really important that you develop relationships with cardiologists that you trust and that, if you and the patient are wondering about a decision that was made, you can seek a second opinion if you want, that sort of thing. So yeah, I
Can I
think,
answer the one more thing? If
yeah.
somebody says to you guys saying that because I said so or I feel so, probably you should get a second opinion.
Mhm. Yeah.
If somebody can give you rationale why they are thinking what they are thinking, if I'm thinking rationally, I should be able to give the rationale why I'm thinking what I'm thinking. Is not my practice was set just because. My practice was set the way because based on the trials. That's called evidence-based medicine. And we should be able to explain at the end of the day, it's your patient, not like truly you refer the patient to me, it's your patient.
Hmm. Yeah.
You're asking me an opinion, I'm providing you an opinion. At the end of the day, patients trust you more than they trust me. Over the course of the time, they might trust me more than you, but in the beginning, they trust you more than me.